You're okay. Yes, yes, yes.
Before we start, thank you those people sitting over there. I knew whatever we did, we would have people doing the opposite of what we want, and it's always Dinesh. For those of you, thank you for coming along. If anyone has still paper votes or manual votes to do, please ensure I hand it in the next 2 minutes so we can finalise the voting. Oh, have we gone live yet, guys?
Yes,
we are apparently live. So for those people out there in the big wide world on the internet, the interweb, welcome. I'm going to hand over now. I'm going to hand over to David to start the proceedings.
Okay, can everyone hear me? Yes. Thanks, Adrian. So, declare the meeting open. First item on the agenda is apologies, and we have 187 of those, so noted. Second item is confirmation of meetings of the previous annual general meeting. I guess everyone's had a chance to read those. Would anyone like to move that they be adopted? Seconder? Okay. Ainsley and William, thank you. All those in favour? Any against? Okay, they're adopted. Is there any business arising from the minutes? No? Okay, we'll do a short meeting. I'll hand over to Adrian to present the report of the Executive Committee.
Cool, thank you. Do you want to bring that back on to me, Ali? Okay, so just, I want to slow things down. We're going really quickly, so slow things down ever so slightly because we do have some, I believe we have some manual votes to count, and it does matter this evening. Can everyone hear me? And am I going out clearly enough on that? Cool. So you can now leave that party and go and help Alex, and then ensure that you bring me that list before we get to the end of my talk. Cool. So again, I've been asked to present on behalf of the Executive Committee. You have in your hands the Executive Committee reports, and I'm intending to briefly talk to that, but I will go reasonably quickly through because it's all there, and certainly I'm happy to take any questions that arise as a result. So first one is Brentry accreditation. The college went through Brentry accreditation this year. We achieved that accreditation, but we do have some specific tasks to do, especially with regards to strengthening supervision, training, approval of training facilities, the facilities they use for training, and also improving the way we do our feedback. And you may have noticed over the last few months, certainly over the last 6 to 9 months, we have been doing more surveys inviting you to provide your opinion. One of those surveys questions was around your input into what you think we should have in terms of objectives or for our strategy. So I'm going to move on to strategy now, and I'll briefly talk about that. So I've started a process of capturing what we are doing, capturing input from the members, from the executive, from almost anyone who has voiced an opinion. And the reason why I've been doing that is because I wanted to be as open as possible to gathering ideas. So I'm in the phase of still gathering ideas, and I have a draft strategy which I want to present a small part of it to you today. I need to emphasize it is draft, it is nowhere near complete, and it does not stand up to any scrutiny or challenge at this point because it is still wide open and divergent. And over the next few months, we're going to narrow it down and get clearer on what we want to achieve over the next few years. I'm purposefully not putting up a vision for the college because it is too wide open at this stage. Here is a mission that I have proposed for the college, that the Urgent Care College becomes a leader in urgent care, bearing in mind that the treatment of conditions that are urgent is much wider than the scope of medicine which you practice, which is urgent care. It does open this up and actually allows us to consider education of patients, of doctors, of the standards for clinics, the standards for doctors, and even input and influence into other aspects of what might be considered care that is urgent. I gathered it was a pile of paper this thick. It was a number of different ideas that people put down, and I managed to move them into piles of what I would consider. I gathered them into a set of objectives, i.e. the main groupings of the suggestions that were being put forward. And they were these that are on the screen. And again, when I am careful about saying the words high quality urgent care doctors, it does not mean we do not have high quality care at the moment. Possibly the word might be higher quality, but then of course we've got to work out how we measure that. So this is a placeholder for something that's going to happen in the future, potentially. This is draft. Urgent care doctors of high quality. High quality urgent care and how it's delivered. Increasing and improving research in urgent care and actually achieving something around that. A clear place for urgent care within the health system. The promotion of urgent care and internally in terms of what we do, high quality, executive management, governance processes and policies, that kind of thing. And if I were briefly to talk about some of those, urgent care doctors, we're already starting to have a selection policy. So as people apply to join the college, we're starting to weed out those that don't fit the standards that we're looking for. We're looking at bolstering training, and you'll notice that we're replacing the practical skills weekend with a skills demonstration and assessment weekend. A review of the training material, having a systematic process to ensure the quality of that training material over time. And included in there is the use of our own data to analyse what we're teaching and whether it actually does promote it does end up with the doctor being of high quality. In terms of delivery, we have the urgent care guidelines, but we're now looking at improving and increasing the robustness of the way that we do clinical accreditation. We have, for want of a better description, a loose target which is based on some modelling, and it's the best we have at the moment in terms of where we might want to end up in terms of the number of consultations that are done by urgent care fellows as opposed to other doctors in urgent care clinics. And potentially Potentially, the influencing of DHBs or anyone else that will listen, so that we can increase the number of urgent care clinics in New Zealand or even overseas. Research in urgent care. We've already started this process. We have a research grant, we have the research paper, and we're starting to look at and explore the idea of a journal in urgent care for New Zealand. And again, using research is part of the idea of ensuring that people are fully aware of what urgent care is and what it's not. And using research to help us ensure that we are achieving high quality care and doctors, that kind of thing. It will also give us an idea of future trends. So technology is changing, care is changing, so it will allow us to look at what is out there that we could be doing in the future. A clear place within the health system. So in my first year being here, I'm acutely aware of the number of doctors, institutions, organisations, DHBs, and so on, that do not realise that urgent care is a separate branch of medicine, that it's a scope on its own. I believe that it's important that the college starts to get a clear idea of what urgent care is and what it's not, and starts to push that, and starts to actually, we'll get clear with a stronger stakeholder engagement. So we'll start to engage more with external stakeholders. So I'm starting to, for example, work with the Ministry of Health to see whether they are fully aware of what urgent care clinics can do and not do. And also that clear place goes back to that reference about urgent care. Or care that is urgent is actually wider than the scope of medicine, which is called urgent care. And then finally, this high quality executive and management. It's really about ensuring that we have a strong governance, we have strong policies, that we have robust processes, even a succession plan for the executive, so that we're looking forwards to the future to ensure that we've got a strong future. What's already happened is we've had a change of rules to cater for some of this, and as you may be aware, through the special general meeting, we now have the ability to co-opt to ensure that we are representative of the members. And ultimately, I want to have strong quality assurance plans in place so that all the policies that we do, all the processes that we do, all the material that we produce has a quality assurance plan of review and updating, and that's captured as we go along. So we can put hand on heart and say, yes, what we are doing is it's professional, it really does ensure that we're providing high quality management. Behind all of this, there are certain principles or beliefs which I think apply here. And the first one, the provision of urgent care in the community requires urgent care doctors and urgent care clinics. Essentially, it's a statement saying, we as a body, we as a college, believe that we have a place, and urgent care has a place, and it's different to GP, and it's different to ED. There is something special that's urgent care, and it's neither of the two. The other parts of this apply, yes, to the college, but also I'm ensuring that we apply this to self. So, our policies, our processes, our marking system, thank you. We want them to be effective, we want them to be efficient, but also to be flexible. We will never be able to write policies that cover 100% of the possibilities. So the idea would be that we write everything for the 80%, and we have the effective processes and policies in place to deal with that 20%. That means we can get, it's the 80-20 rule in a nice simple form. We do a lot more, we get a lot more bang for our buck. Looking at innovating, so this is use of technology, and also innovation in terms of training to improve what we do as a college. Patient-centric approach was one of those principles that was suggested to me that we need to have, so that as we write what we do, even including our strategy, we should be focused on the patient. Now, that's one that I would also put a question mark against. It's very important, but my question would be, well, we also have to consider, is it right for the health system? Is it right for, so we have other approaches that we could take. So this is one that I think we'll end up having this one, but we need to be aware of what we're taking out when we do this. And finally, the importance of well-being for the workforce. And that applies to the idea that urgent care can complement GPs, and if we can complement the GP practice, the GPs can then reduce the load on the GP workforce. Urgent care itself needs to incorporate the principles of well-being into doing what it does. And I know many of you work long hours, and I think so it's important to have this as one of our principles. This I'm applying in terms of well-being, I'm applying to the office itself, so that we are ensuring that we have a strong, happy is the wrong word, our office itself is efficient, effective, and we can achieve a lot without straining what we do. So this is just a distillation of the notes that I have. As I mentioned before, it's very draft. This will be put into a form that I will then share with the future executive committee. I'll interview anyone that wants to chat with me, and I will again repeat this process. The next phase will be to gather a little bit more input, prepare this for feedback from the members, but also have a workshop with the executive committee. So I'm looking at towards the third quarter of the year, September time, to have a strategy that can be then, a final strategy that can be then shared with the members, with external stakeholders, and then ultimately implemented as part of our strategic goals. So that was the strategy. So I went sideways, so back to the executive committee report. Are there any questions about the strategy and the approach that we're taking? Fantastic. Back to the executive committee report. As part of the branch reaccreditation, there were a few things that we were invited to look at to add further policies to what we do. Many of our policies were overdue a review anyway, so I'm taking the lead in making sure that we restructure and review the policies, and again, the aim being towards the end of the year having those complete. As a result of feedback, we've adjusted the size of the future executive committee and how it's voted. We also have the rule about representation, so the executive committee has to ensure that it is representative, so we will always have a North Island outside of Auckland representative, a training representative, a South Island representative, and so on. Who's responsible for what? And I'm hoping to have that achieved in the next few months. And finally, something that was adopted last year, the committee members, and in fact anyone, this is actually open to anyone, either over on the internet or here in the room, anyone who works, who supports the college on tasks and projects. We do have a policy around remuneration. That's also a word that I find difficult to say. But we do have a policy around how much we pay you. It aligns with the medical council rates. So the medical council pay a certain amount for those who are supporting the contract roles. We do the same. And finally, we're taking on a Director of Professional Development, if I dare throw that title in, because we haven't finalised that title, a 0.5 FTE role to look at the professional development aspects of the college and fellows. E-portfolio, so we've successfully loaded all the fellows. We're in the process of loading all the registrar's CPD information and still working with BPAC to finalise the training program pages so that all registrars can go to e-portfolio for all aspects of their training, both the training requirements and their CPD. In the meantime, we created an in-house prototype. So those of you who are registrars will have seen what we call the training program summary, which is a simple prototype of where we intend this to go. We've had good feedback. Hopefully it is more useful to you in terms of what you need to be doing to achieve your fellowship. The coat of arms. 2 days ago, I finally received notification that there is this piece of leather sat in Wellington with a coat of arms on it. So we were gazetted last November, apparently. I didn't know about this until we received a spurious email from someone in New Zealand saying, "Can you tell me about your coat of arms?" So that coat of arms is now finalised. It's with the Heralded Arms in Wellington, and we're planning to pick this up and collect it, formally have it handed over, and then ultimately I'm giving ourselves until early September to have that converted, scanned, converted, the image converted so that we can use it in our various forms to have the various logos designed, so that by the beginning of September we will be able to launch this as a formal press launch. The website, the current website is interim. We did have problems with our original provider. They pulled out. We've now got someone else on board. I'd like to point out at this stage that Hardy sat over there nice and quietly. Hardy is, he has skills in website design, so much of what we're doing is in-house, and at the same time we recognise the technical limitations of his skills and my skills. So we have the support of an external provider that's very happy to work with us in this way, where we do what we can do and they support us and do all the other stuff that we can't do. And it's working very well so far. The aim is for the future website to be launched around early September with the new coat of arms, the new crest, so we have everything happening at the same time. The Australian faculty of the college has been running for a year. Dr. John Adey, I'll invite him up in a second to give you a brief report on what's been going on. And then in terms of numbers, I've got the training program numbers. I'm not going to present all the statistics that we presented before. We are a strong college and we continue to be strong. Training program numbers have gone up, I believe. Yeah, they are going up steadily. So this is the 2017 does include a few people who are still to finally accept their place on the training program. But we are steadily increasing our training program numbers. 2018, we already have, I believe, 22 accepted onto the training program. So, or about to be accepted onto the training program. So in terms of training applicants, this is bearing in mind that we are filtering out people who are not meeting our entry criteria or even our selection policy. So we continue to grow. In terms of funding, I managed to tweak the contract with the Health Workforce New Zealand, so I can use the funds in almost any way I want as long as it's for the training program. That releases us from a whole host of issues in terms of how the money had to be spent. So now we have this great flexibility means I can use the funds in a way that's far cleverer than it was before. Looking forward to 2018, 2019, the focus will be to complete the strategy, to get the coat of arms up and working, to get the website up and working, to continue to do some of those things which are clear winners in terms of the strategy. Promoting urgent care. Finalising the policy. Obviously, we have those tasks to do for branch accreditation, finalising those. We have the first inaugural skills demonstration and assessment weekend, where let's say that's the replacement for the practical skills. And finally, a teaser, the inaugural fellowship dinner, which will be launched at the same time as the crest and the website, aiming for that to be early September. So that's the executive committee report, and it does need to be moved and approved by the members.
Role of the professional development, the director of professional development. What's what they're going to be doing?
Sorry?
We might get somebody applying out of this audience.
Yeah, so very soon, Alistair will be able to release the job description. I'm getting maybe a nod over there. But essentially, Alistair may be able to talk better about this in terms of the bullet points of do you want me to have a go?
Why don't you have a go, Adrian? I mean, I think what we've identified, and it's really been, I think, for at least the last 12 months, is that whilst we have the new position of Director of Clinical Training, and that's really concentrating on managing the training and the monitoring support of registrars. We've been perhaps lacking around some of the equivalent for fellows, both in terms of managing CPD, managing ongoing competence, and in terms of our accreditation report from the Medical Council, they have put some suggestions through where we need to strengthen some of the processes around what we do with fellowship. So the role will be broad, both in terms of the CPD requirements and monitoring and also supporting fellows. We're also looking at some of the new requirements that the Council has said that we need to put in place around supervisors. Our supervisory role has been, I think, more informal than formal. Increasingly, we require that to have more structure around it, more formal support. There will be more requirements on supervisors. They'll need to be well trained. It can't just be anyone. And therefore, there will be a reporting process that both we ourselves and the Medical Council will require. So we need someone to manage that process as well. Adrian, do you want to add anything to that? No. So we're looking at a 0.5 FTE minimum position. As you can imagine, the job description, when we look at how many things we'd like that particular role to take on, went from here to about there. And we've had a lot of feedback and discussion from the executive committee members. So we're up to really draft 3 in terms of that role description. The intention is to have it out and finalised within a couple of weeks, and then the application process for that role and interviews, shortlist and appointment, we hope within a month or 2 after that. It's a key role, I think, in our view, for the next few years in terms of the fact that we're growing as a college and the requirements on all colleges, not just our own, from the Medical Council are increasing.
Thanks, Al. Are there any other questions on the Executive Committee report? Okay, would anyone like to move that we adopt the Executive Committee report? Seconder? In favour? Against? Okay, I'd like to ask John Liddy now to come and talk about the story.
Very grateful to the exec for giving me the opportunity to represent the college in Australia over the last year. My urgent care journey started the first time I went to Australia in 2001, and that was 6 months after I got my fellowship and 3 days after Westgate Medical Centre was visited by the Accreditation Committee to allow us to be an urgent care centre. And what I found with the fellowship that most of you helped with was that when I went to Australia and started work as an emergency and trauma reg, this is because they wouldn't let me work in the city for 10 years, I had the skills to do that, to work in the second busiest emergency department in Australasia, unsupervised overnight. It was great for training, but it was not only that. It was also a title that I could go to the professor that ran our clinic, Professor Chris Bagley, and talk about urgent care in Australia and New Zealand. And he's just most recently been the Chief Medical Officer of Australia. He was for the college. So it was those 2 things, but it wasn't all that. Urgent care is a key to unlocking high-quality, patient-centred, cost-effective medical services in a patient's community. And I'll say that again because it's something that I haven't realised until I've actually gone to another country and we actually look at what's done in New Zealand and envy it. High-quality, patient-centred, cost-effective care in a person's medical homes. Looking at Australia over the last 10 years to 2012, the cost to the health system or to the actual government has gone from 18 to 24% of tax revenue. That's over 10 years. So if you fast forward that, more and more money is being consumed by health dollars from what we're doing. And urgent care provides a key to reversing that trend. So with that background, I want to give you 4 ways that we've been working in Australia to advance the cause of the Royal New Zealand College of Urgent Care. The first is innovations in practice. So when I went there in 2014, I sold my practice at Greenwith Medical Centre. I went to do a PhD on management of non-life-threatening urgent conditions in the community. I got given Sippy Downs, which is a 3,000 square metre general practice with 4 GPs, no patients, in the most overlooked area in Australia. So things weren't looking so good for us. We went to the local hospital, and one of the execs had just come from Wellington. She'd worked for 8 years with urgent care centres. And we said, how can we serve you? They said urgent care, ambulance diversion, fracture clinic, and hospital in the home. So we went to work on that, and within 2 years we got the RACGP Queensland Practice of the Year. It was a very successful, very profitable practice just from using what the urgent care teachers people do in New Zealand. Through the PhD, the literature review, a local hospital that's basically built a new $2 billion hospital had an urgent, an emergency department that was freestanding, but they wanted to keep it open. And we met a lot, and I said to them, make it a public urgent care centre. So it's one of the first public urgent care centres in Australia. It's been going for about a year now. It's going really well, and we've based it on the Royal New Zealand College of Urgent Care model. The most recent project is Health Hub Doctors Morayfield. I learnt about the project about 18 months ago, and I'd like to ask Dr. Evan Jones to stand up at the back there. He's the brains behind all this. So Evan bought a Bunnings and approached an investment company to drop $100 million on this Bunnings. So about 4 months ago, we opened a 90 GP plus 38 bed urgent care centre with ambulance diversion. We've got a 20-metre pool on the second floor. We've got day oncology, gastroscopy, colonoscopy, dialysis, 15 registrars, 19 child care unit, coffee club, and the list goes on. Amazing foresight, but again, we're basing it on urgent care in New Zealand. We've just taken the models that we've used here and we've just expanded them and built on them. And a lot of this is the basis of the research that we're doing. So the first way we've hopefully expanded the urgent care college's role in Australia is innovations. The second is research. So there's 5 areas of research that we've done, and I just put a few of these articles and posters that we've taken to places like British Medical Journal on the way in, and certainly if you want a copy, ask the girls and we'll fax those to you. The first one was hospital in the home. We started with POAC in New Zealand, kind of put that on steroids a bit. So instead of the COPD, asthma, rehydration, those sorts of things, what they did is instead of the patient staying in the hospital, they would allow us to send nurses to an hour radius of where we were,